Thank you all for joining us. I'd love for each of you to share a little bit about your background and talk about how your professional and or your personal life overlaps with celiac disease. Sarah, you can kick us off.
My name is Sarah. I am a registered dietitian and a certified diabetes care and education specialist. So I work with kids with type 1 diabetes, which is an autoimmune disorder. So a lot of our kids do have celiac disease. I personally, I have cystic fibrosis, type 1 diabetes, and I was diagnosed with Crohn's disease 20 years ago. And then in my 20s in college, I was getting really sick. My diabetes was really out of control. And the only thing that my doctor said, like, do a low glycemic diet, which is supposed to help with blood sugar control. But turns out that when I was doing a diary, I realized that gluten was the issue. So because celiac testing for me wasn't necessarily a positive or negative, it was decided best just to go completely gluten-free. So for 13 years, I followed a strict gluten-free diet, diabetes, great control. CF, it has a big impact with inflammation, so that's been good. And my GI system thanks me greatly.
Hello everyone, my name is Eugenia. I'm currently a gastroenterology fellow at Mass General Hospital. So I take care of a lot of patients who have celiac disease, and I've also had the privilege of doing some research with patients who have celiac disease, so that's how my life overlaps with this condition. Right.
So good morning. It's wonderful to see everyone in this room. So I am Ritu Verma. I'm a pediatric gastroenterologist. And on behalf of the pediatric gastroenterologist, I apologize to all the teens where we say it's just you're a teenager. So I apologize if your diagnosis is not made. So I currently am at the University of Chicago, and much better weather there than here. I was in Philadelphia for 30 years, so it's been fun seeing the transition between what happens in the Midwest and the East Coast. I've known Alice for a long period of time, so if I'm here today, it's mainly for Alice, but also to be part of this community. I have 2 children who have celiac disease. I do have the genes, and we can talk more about the genes in celiac disease if we want to. But I have 2 children who have celiac disease, one asymptomatic and one with symptoms. And yes, it's a curse and not a curse to have symptoms or not have symptoms. So I am a parent of children. I've lived it through my children, and I am a pediatric gastroenterologist who runs a celiac center at the University of Chicago. So again, apologies to the young people who haven't been diagnosed.
My name is Ehrlich. I'm, amongst other things, the board chair of Beyond Celiac. I'm a family physician in central Massachusetts, and I've had celiac disease for about 10 years. One of the things I try and do is I speak on celiac disease to primary care physicians to educate them so that people won't have the experiences that many of you did have, and I'm doing my best to spread the word. And yeah, I live with celiac disease. I'll just give a brief anecdote. I was eating dinner with colleagues in Boston just the other night, this week. I ordered what was supposed to be gluten-free pasta. It was obvious there was some kind of problem with communication with this waiter. And when the food came, I said, is this gluten-free? Because if you have doubts, we all know eternal vigilance is the life we live. And the waiter says, no, it's not gluten-free. Right? And this was just the person who served. So when the other waiter came, I said, I can't eat this, it's not gluten-free. And they apologized and they took it back. And then I did get a gluten-free meal. But this is the reality that we live in this society, that people don't take our illness with the degree of seriousness that so many other illnesses are treated. So I'm so happy to be here. I'm so happy that all of you are here, that we can perhaps share stories and share information so that we all can live a little bit better life after today is over.
How safe is it for a gluten-free child to be living in a shared gluten-free household? And Ritu, I'm going to start with you on this one.
So I think it's very safe. I guess the question should be how stressful is it for the parents and everyone else. But it's absolutely safe to be in a household that has gluten and gluten-free. The education is the key. So everyone needs to be educated in terms of how to do it, and talking to your clinical team how they can help you manage a dual kitchen. So I'm all in favor of dual kitchens. Education, learning is the key.
Sarah, how do you talk to people who might be living, even if they're not a child, but they're sharing a house with people who aren't gluten-free?
So working with type 1, a lot of our kids are screened at diagnosis for celiac, but we don't start them on a gluten-free diet until they see a gastroenterologist. So at first we have to, it's hard for us, but we have to encourage that they continue to eat gluten, because we can't give you have to start eating gluten-free. So we get all those follow-ups going, but since a lot of the changeover happens with the type 1 diabetes diagnosis and the celiac diagnosis, we just encourage healthy eating throughout the whole family, and then separating where you can so that they have their dedicated snack area separated from the kids, because it also works with what they can have with the new diagnosis of diabetes. So we kind of just ask them to separate things, but then we just guide whether it's their hand washing dishes, or if they have a dishwasher, if they need separate, because I don't know if any of you know, if you're using a sponge that had gluten on it and then you're hand washing a pot that is gluten-free, sometimes those things can mix. So that's really the cleaning, but we say you can use the pots and the pans and the dishes as long as they're safe and clean. But the snacks, because it goes both ways, so it's kind of when we're making one change, we just make the whole change for them. So that's kind of what we do.
Dual kitchen, I'll give you my own experience. So I have 3 children. 2 of them have celiac and 1 does not. So when the kids got diagnosed with celiac disease, of course, I was the crazy mom who took everything out of the house that had flour and stuff like that. So no one could have anything in the house. And it really was a bad impact on the middle one, who did not have celiac disease, to not have a home where she could call her own home. So over time, learned from my children. I think we all learned from our kids. So we had one part of the kitchen that was gluten containing. So there was bread and, crackers and Pop-Tarts that she liked that were there at that time. And then the rest of the kitchen was gluten-free. So I think it's doable. It takes a little bit of an effort, but you've got to think about the psychological impact of all the other people who are in that home that cannot have the gluten containing foods, just because it's their home as much as the child or the parent who has celiac disease as well. So over time, everyone learns, wash my hands, I go into that corner, I don't go into that corner if I have celiac disease. You work through that, and it's an effort, but it's doable. But always think about the psychological impact of what we are doing as parents or spouses or whatever, taking out the foods that others can eat. And then we won't talk about the expense, but I think just the psychological impact is huge, not to have everything for everyone at home.
How do we protect ourselves and understand better what is vigilance and what is hypervigilance? So I'll let any of you take that.
Well, I haven't had much to say yet, so I'll chime in. I think with the last question, this question, one of the most important things to keep in mind is that people with celiac disease have different sensitivities. Some people can tolerate more than others. When food is labeled gluten-free, it does not mean there's no gluten in it, okay? It means it's below a threshold that the FDA has set. And so some people will react even to very, very low levels of gluten. Some people tolerate a bit more. So how vigilant you are has to be in part based on how sensitive either you or your child is, and things like that. So that's I think the first thing to avoid going overboard. Gluten isn't this sort of invisible thing that's going to sneak up on you in the middle of the night and get you, okay? It's real, it's tangible, but modest efforts to live sensibly, I think is the key. Because you don't, you're talking about the psychological damage to the child who doesn't have celiac disease. There's equal psychological damage to children or others who are so obsessed with, I can't possibly ever, get exposed to cross-contamination. When I get exposed, I get sick, I don't like it, but it's also a little bit of the price of living in the real world. And so you want to minimize things, but zero tolerance maybe has downsides to it, just as it does in so many other aspects of society.
Alan, you're so right. This is something that we all need to remember, is we have to live in this world, right? And there's both gluten and there's gluten-free. Again, I'm a pediatric gastroenterologist, so I'll talk about children. To be able to tell your children that you cannot go out to eat, or you cannot sit next to someone who's eating gluten, I think putting it in perspective, if you touch gluten, it's not a problem, right? It's when you have to touch the gluten and put it in your mouth is a problem. So washing hands, I saw someone the other day and the young lady says, the patient, she tells me, Dr. Verma, you asked me too many times to wash my hands. I'm not washing my hands. But I think wash hands before you eat. So that education piece and making your children realize you have to live in this world. How do we live in this world happily? Right?
Yes, you're 100% right. I have to tell a story. It's about my cousin. He was a little boy. My uncle always wanted him to wash his hands before he ate. And at some point, as you can all know, little boys become very obstinate. And he would refuse to wash his hands, and it was a big battle until my uncle finally said to him, okay, you don't have to wash your hands before you eat. You just have to wash your face. And for years, he would wash his face until he realized his uncle had tricked him. My uncle, rather, had tricked him, yeah.
Yes. But hypervigilance is probably one of the worst things that we can do to ourselves if we have celiac, and to our children when they have celiac disease as well.
Eugenia, do you see that in your adult patients with celiac disease as well, getting hypervigilance?
Yes, I definitely see that. It affects their social lives sometimes. Even just like going out to hang out with friends becomes kind of a problem. They feel isolated, and it's just like something that we talk about and how to navigate that, because everyone wants to have a social life. Everyone, like just because you have celiac disease doesn't mean you don't want to hang out with your friends, so.
What is being taught about celiac disease in med school these days?
Yes, so I can only speak for what I was taught at my med school. But we were very fortunate to have the person who taught us about celiac disease was very, very excited about celiac disease, was my mentor, Benjamin Lovell, and he kind of got us up to date with everything, even with false ideas about celiac disease and things that we need to disperse. Oh, it's a rare disease. No, it's actually more common than we think. Oh, it affects a specific type of demographic or a specific race. No, anybody can get it, It can present, if they don't have diarrhea, then they probably don't have celiac disease. No, there are many, many other manifestations, and it can present in different ways. How do we talk to patients? How do we diagnose it? How do we manage it? What are the associated conditions? So it was kind of really thorough, my experience, but this is not to belittle every other person's experience with people who have been misdiagnosed or undiagnosed for years, because I do get those patients in my clinic who have been symptomatic for years, and it's kind of it was a missed diagnosis. So, yeah. So I was fortunate to have a good experience where we were really well taught about celiac disease, but I understand that it's a problem in the medical community.
Ritu, what can you tell us about what has kind of changed in maybe the last 10 or 15 years about what students are being taught? And when you work at a place with a celiac disease center and a med school, is there any kind of extra education, or do you think the UChicago med students are better educated about celiac disease because the celiac disease center is there?
I would say yes. No. I think it depends. It's exactly what you said. If you have a teacher who is a passion for a particular condition, you end up learning more about it. In the curriculum itself, there's a change that medical students are now being taught more about nutrition, and they're being taught about cooking, and they're cooking demonstrations and so on. So there is a change Is it where it should be? No. But there's definitely a change that is going through medical schools because there's an awareness, not just from a celiac standpoint, but just from a nutrition, eating, and then bringing in celiac disease. But I think beyond medical students, I mean, we have residents, you have physicians, and Alan's doing a lot in terms of educating practitioners that are family practitioners. The celiac centers across the country are hosting more educational events. I think that is definitely moving forward. Are we there where we should be? No, but I think, is it much better in the last 10 years? I would say absolutely yes. So the celiac centers, and we have organizations like Beyond Celiac that are also helping out with the education piece. It's moving in the right direction, though. I don't think we should lose hope.
If I can just say a couple things. One is, I think knowledge about celiac disease is getting better in medical schools. It's not nearly where it needs to be. And in particular, we were having this session a little earlier this morning, raise your hand if. Raise your hand if you have brain fog or other neuropsychiatric symptoms when you get exposed, okay? That isn't being discussed in any meaningful way with the people who need to know about it, particularly primary care folks. And in addition, we're here talking about medical schools, but so much of the future of particularly primary care, where the celiac disease needs to be recognized, is in nurse practitioners and physician assistants, and they are not being educated along these lines either, and I do what I can for that.
Sarah, what can you tell us about what you learned about celiac disease as a registered dietitian in your training?
So I'm going to do it from two point of views. So as a registered dietitian, a lot of cultural preferences, intolerances, allergies, and different diseases are covered in our undergrad. When you do you have to do an internship, which dietitians kind of refer to as like medical school for dietitians. It's a lot more concentrated, and you can kind of do more of what you like depending on what internship you choose. So we do learn a lot more, I feel, than our counterparts, which were registered nurses. Nurses don't get as much education about celiac disease or different cultural preferences or intolerances as dietitians do. So you see it even as a patient perspective. If I've been in the hospital, nurses don't necessarily know what gluten-free is or celiac disease. So if you ever come in that situation, explain it the best you can and advocate for yourself, because as a patient, I have seen that whole wheat toast has shown up on my tray or white bread, and luckily, my mom or my husband would be in the hospital to advocate for me, but sometimes you're the only one that can advocate for yourself. So just advocate, because it's not that they're being naive, they just aren't taught it in school.
So when we're thinking about how someone with celiac disease should manage their disease, what is the role of the dietitian?
So the dietitian, we talk about overall eating habits. First, we kind of start from that base, and then the different foods that have gluten in them. So we talk about, barley, rye, et cetera, cross-contamination, how that can affect the GI system. If there's no symptoms, if you have gluten, if there's symptoms that you have gluten, what to look out for. Something, as that we're saying, is the slight asymptomatic. A lot of my type 1 diabetes patients are not symptomatic, but we notice it in their blood sugar management. So that's kind of a little bit of a hidden symptom, I guess. But it's just really concentrating what foods have gluten, what foods don't have gluten, and working from there, depending on where you're seeing the celiac being diagnosed.
Eugenia, could you talk a little bit about what the role of a gastroenterologist is for an adult with celiac disease?
Yes. So beyond diagnosis, our goal is to make sure that it's adequately managed. We after like a certain time on a gluten-free diet, we really want to go in back with like an endoscopy and make sure that all like your small intestine is well healed. Even though we are privileged to work with very good dietitians, we kind of also want to talk about it a little bit and also figure out how the managing disease is affecting their lives, equip them with strategies to feel empowered and advocate for themselves. So that's kind of like what we do. And also like health maintenance as well, the vaccines that are needed, because sometimes we see like the primary care physicians may not be up to date on that, and also like looking for some associated conditions that may come up as well that may be associated with celiac disease. So that's kind of how we approach it. Yeah.
And I'm just going to do a follow-up real quick because this is on the list too. How frequently should an adult with celiac disease get an endoscopy after their diagnosis?
So usually around 6 months to 1 year after the diagnosis, we kind of do one to make sure that everything is well healed. If that's fine, routine endoscopies without a change in symptoms, we typically don't do in adult GI, except something changes.
Great, thank you. So Ritu, the pediatric side, what's the role of the pediatric GI, and then how frequently should kids be getting an endoscopy after their diagnosis?
So from a pediatric gastroenterologist, I think it's important, I'll go back to education. I think it's important for the family to know why they're going through this testing. Not everyone embraces celiac disease like this group does here. So it's important to educate why, if their child doesn't have any symptoms, they still need to stay on a gluten-free diet. So the first is the diagnosis itself. Even if you have no symptoms, you need the diagnosis made. This is where that discussion happens between the gastroenterologist and the families, because I'm sure people have heard about the non-biopsy diagnosis. So this is a discussion that happens with the family, and it's a decision made. It's shared decisions on whether you're going to do a biopsy or not for your child. So that's the first part of it. Once the diagnosis is made, then it's important for the child to understand what diet he or she needs to be on. Why does he need to be on it? Why does she need to be on it? It's not just because my mom said so, or my grandmother said so, or my dad said so. It's because there is a whole disease process. So one of the things we do in our center is educate the child based on their level of education. In terms of, you're a toddler, you're not going to go through autoimmune crisis with them, but if it's a teenager, they need to understand what is the implication of eating gluten. So throughout the lifespan, we are educating, we have classes for these children at their levels, at whatever age they're in. The next thing we talk about is, how do you live in this world? So for the kids who are going out with their friends, we sit down and we talk about which restaurants can you go to. We role play with them in terms of how do you ask questions, not just rely on your parents asking questions. Empowerment for the patient, for the child, is one of my most passionate things when I'm talking to the families. That child is going to grow up and be sitting in this room and not worry about what to do, because he or she knows this is what celiac disease is all about. So empowerment for the child in every visit is important. It is the key to really management for the future for these children. As far as, and then, we go through 504 plans for schools. If you're going to school, you've got to be accommodations. A child with celiac disease shouldn't be put in another room to eat. They should not be sitting at another table. They should have the same healthy gluten-free meal as someone else who has. If your school has hot lunches, then we work with your school to get hot lunches that are gluten-free, safe gluten-free foods for your children. So that's part of our job, and to work with you, but the child has to be the important part. So as a parent, I could say, oh, my child should have a hot gluten-free lunch every day, and the son might look at you and say, I'm not standing in that line. So we go along with what the child wants, with some discussions about what should be done and so on. So 504 for every time, and then when they go to college, and Alice has heard me say this many times, you don't go to a college because they have a gluten-free dining hall. You go because you want to be in that college, and the rest is for us to help them. So empowerment of the patient is a key for management in pediatrics. The parents are important, the grandparents are important, they're kind of there for the ride, but the child is the most important thing. And how do you work in a family? You have Thanksgiving, there's gluten-free, there's not gluten-free, work with the kids with that. As far as repeat endoscopies, it's not the norm in pediatrics. There's a movement going on in the pediatric celiac world that perhaps in a few years after you've been diagnosed, you would get an endoscopy. That's not the norm. If your blood tests are not improving, your symptoms are not improving, then yes, you get an endoscopy. If your first endoscopy showed something else besides celiac disease, then yes, you get a repeat endoscopy, but not the norm in pediatrics.
Alan, can you talk a little bit about the role of the family medicine physician or what the role is, if there is a role?
So I think, if you think about a typical family physician, internist, primary care provider, they may have a panel of, let's say, 1,000 patients. And given the rates of celiac disease, that means they got between 5 and 10 patients in their practice who have celiac disease. It's hard to gain a level of expertise with such a limited exposure. And so I think some of the role of the primary care provider is to help the patient navigate the healthcare system and to get them to people who can give them the information or care that they need. So one of the things that should be, it's part of the guidelines from the gastroenterology groups, and it should be part of standard care, is a referral to a dietitian once the disease has been diagnosed to help with giving a lot more of the information that the primary care physician doesn't necessarily have or have the time to provide. So that's one thing. The second thing is, I listened to what you said about, and the question, how often should the person with celiac disease be seen by their gastroenterologist? Well, from where I sit, access to gastroenterology is very difficult. They spend so much of their time doing procedures that the time for a consultation with a patient with celiac disease who may not need a procedure at that moment, there just isn't the capacity in the system for that to be the norm everywhere. I think it's the ideal, but the reality that I think many patients face is they get by with the best they can, and the primary care physician needs to fill that gap. So it's a combination of, if they're prompted a lot, well, I'll say this, modern technology helps a lot. I know in some of the situations where I'm teaching, the nurse practitioners or the PAs, they can do a e-consult with the gastroenterologist. They can ask a question and get an expert answer without having to book an appointment. And so things like that are ways that you can bridge the gap and get the kind of care that we're talking about here.
So it's hard to in defense of the gastroenterologist, it's hard to get the primary care to do some of those labs and things. So I think that partnership is important to know.
You're 100% right. Things like monitoring for autoimmune thyroiditis, okay, or hypothyroidism, just getting a TSH, or ordering bone density scans at a certain point in life. These are things that are these are routine tests that primary care people do all the time, and getting them to understand that is part of what they need to be doing for their patients, I think there's still work to be done there.
Alan, what are some common comorbidities with celiac disease? We heard a lot of thyroid disease out there. We coined a new disease, gyroscopic colitis. What else do people need to be worried about or watching out for, maybe not worried about, but just aware of that could be a comorbidity of celiac disease?
I think when we use a term like comorbidity, I think that someone was saying we should speak in plain English. I think that was the advice we got. Yes? Okay. And so, some conditions are complications of the disease. So for instance, osteoporosis, weakening of the bones. That is something that happens because the disease inhibits the way calcium is used in our body, the way we absorb it and whatnot, vitamin D likewise. That's a complication. Something like type 2 diabetes is type 1 diabetes, my bad, is a comorbidity. You have both of those together. It's another disease you have at the same time. And then you have things what I would call manifestations. Okay, so the diarrhea, the vomiting, the gastrointestinal manifestations, and then we have what we call the extraintestinal manifestations. Extra meaning outside of the intestines. And so things like the neurocognitive effects, that's an extraintestinal manifestation. The reproductive effects, problems with recurrent miscarriages or infertility or things like that. These are all manifestations. And, so when we use a term like comorbidity, it sort of lumps all that stuff in together, and I like to tease those apart. But I think those are probably some of the most important ones. There's clearly neurologic aspects. There are skin aspects. Did anybody, you don't have to say, I'll just say, there are a certain number of people with dermatitis herpetiformis, a skin manifestation of celiac disease. So you have that. There are other skin manifestations. Some people just have eczematous outbreaks or things like that. I wish to, ask my colleagues here. Do I get to phone a friend here?
Yeah, phone a friend. Anyone can jump in.
Oh, yes. So other things, you did a really good job explaining, like the complications versus comorbidities and other extraintestinal manifestations. Other things that we think about are, a lot of them are other autoimmune conditions, like some people may have ulcerative colitis or Crohn's, or there are also some peripheral nerve disorders that can be associated with that, with the disease as well. We talked about like the weak bones, the osteoporosis, and how we need to get screening for that. We talked about type 1 diabetes. We talked about skin manifestations. Trying to think, it's a very, very long list. Some people like have other associated conditions like migraines. There's an increased risk for neuropsychiatric disorders as well. Mental health is also like a big issue. Are there others I'm missing?
I think I'm going to go back to the late term autoimmunity, right? So what does autoimmune mean? Like we keep talking about autoimmune diseases. So it's really in celiac disease, your immune system is reacting and causing some of these other conditions. But I'm going to go back to what you said. Is this truly a consequence of celiac disease that we missed because we didn't make the diagnosis? So it's really not a comorbidity per se. It could be a symptom. So some people get diagnosed with type 1 diabetes first and then celiac disease. So almost 5 to 10% of people who have type 1 will end up with celiac disease. But if you go from head to toe, hair loss, alopecia, your thyroid, migraines, depression, anxiety, skin, pancreas, liver, so really go anywhere down, those are, you could call them either complications or you can call them the symptoms, but any organ in your body can get affected if you have celiac disease and only if you continue to eat gluten. So it's really important to remember that not everyone who has celiac disease is going to end up with one of these conditions, but it's something to be aware and those should be managed. So as you do your follow-up visits, those are the things that we are monitoring and our colleagues in family medicine are doing that.
I just want to be clear. I lost hair even though I was on a gluten-free diet.
See what happens?
Yeah.
Didn't work.
Didn't work.
So if you have celiac disease and you want to talk to your family members about getting tested for celiac disease, how can you have that conversation? What are some tips and all?
I deal with adults. I'm sure with kids it must be much harder. But I think something you can tell your family members, first of all, be willing to disclose the diagnosis to them. I feel like it depends on what kind of relationship you have with said family members. Like, hi, I have celiac disease. It's when people have a family member who has celiac disease, the risk increases by 10 times. So I think it would be great if you consider getting tested for it.
So who is at risk? Like which of your family members?
Your first degree family members are the ones that we typically recommend testing for. Like your sisters, your brothers, your mom and dad, maybe. Those are like the people in your immediate family. It's kind of what we would define as your first degree family members.
So you don't have to call up great Aunt Betty and
No,
let her know
you don't have to text the family group chat.
This is a tricky question in terms of, should family members be tested or not? I think the key thing is a conversation needs to take place. People need to understand what are the risks and benefits of being tested. The risk is, of course, or the benefit, of course, is finding out about a disease that can take a long time to diagnose, as we know, and can have a lot of unusual manifestations. And it may be harming the person internally before they recognize it, and you can avoid that. That is the good part of it. The bad part of it is what we all know, that it alters your social functioning in a major way. It really represents a sea change in how you're living your life. And there have been some studies that show when you diagnose someone who's symptomatic with celiac disease, their quality of life gets better. But if you diagnose someone who doesn't have any symptoms, and now you tell them they have celiac disease, well, their quality of life gets worse. Okay? Now, it doesn't mean their health gets worse. Their health probably gets better, or it's protected longer. But you have to have a straightforward conversation. People have to know what they're getting into. And so, if somebody says, and I have family members, my children, who have not been tested, some have not. But what I try to impress upon them is celiac disease has many, many different symptoms. So if you're having something that isn't getting better, that may be a sign of undiagnosed celiac disease. So even if you don't choose to get tested, you want to have a low threshold for subsequently getting tested in the future. The other problem is, okay, if if everybody gets tested today, they may be negative for celiac disease. That doesn't mean they can't develop it in 5 years. Now, you can go with genetic testing, which might help, but that's part of the problem, is how often does that have to be repeated, or things like that. So it's not a simple yes-no decision. There are a number of facets that at least I try and make people aware of.
I don't give them a choice, but you're absolutely right. If you don't have symptoms, then you have to know what you're doing with that. So in pediatrics, all the siblings get tested, and I really don't give them a choice. Give a lab slip and say, here, go get the blood work done. Don't even have to go anywhere else. I don't give the parents a choice. I make them feel very guilty that if you don't get this done, what kind of a role model are you for your children, all right? So the testing should be done for first-degree relatives. Yes, education and teaching needs to happen, but that testing needs to happen. And as Alan said, it's really important to remember that just because you got tested once and it was negative, you're in the clear for life. Unfortunately, you're not. So you need to get tested routinely. And that, I think, is where we go with, do you do every 3 years, if you do 5 years? And then remembering, if you have one of the symptoms that's not even the traditional symptom, you should get tested again. Not that every headache equals a celiac test. So that's important. And I think, if the first degree relatives, I honestly don't give them a choice. They've got to get that done. But the second and further on, it's their choice. You educate them and you tell them these are the long-term complications that can happen if you don't get tested and you don't find out. So it's their choice. But the others, no.
I'm just curious, how many people here who have celiac disease have a first-degree relative that's not been tested? Okay, so not a trivial number, yeah.
You need to get another session like this for those first-degree relatives so you can educate them on why they should. You can only do so much in terms of educating and getting people to get the testing done, but it's important.
We know about celiac disease testing. If you have symptoms, could someone talk about the role of genetic testing and how that's different from testing for celiac disease itself, and when you might use genetic testing?
Yes. So for genetic testing, what we test you for is for this particular type of gene. We call it HLA-DQ28. So it's interesting. If you test people in the general population, about 20% of people have it, but only like 1% of those people will go on to develop celiac disease. So this is to say that if it's positive, it's not as helpful, but if it's negative, then the chances that you have celiac disease are probably 0. So the testing is only helpful in that you need it to be able to develop the disease, but just because you have it doesn't mean you're gonna get the disease. So how I use it in my practice is a patient comes in, they said they think they have celiac disease, but they've already been on a gluten-free diet for years. They cannot go back on a gluten-containing diet because they're just gonna feel so terrible. I talk about it, and I talk about we think it is worth it to do the 6-week challenge to get a diagnosis, because I think it really changes how we can care for you. But some patients are they can't tolerate it, so we do the test. If it's negative, I'm you're in the clear, you don't have celiac disease, but if it's positive, we're still in the same boat. So that's how we use genetic testing.
So it's a blood test. And the advantage is you could do it if you're eating gluten-free diet, but not the most helpful test in real practice, but it's a blood test that can be done.
So let's pivot a little bit. So if you're diagnosed, a lot of times because celiac disease affects the villi in your small intestine, which helps you absorb nutrients from your food, sometimes you can have nutritional deficiencies. So Sarah, can you talk a little bit about if you know, if you're diagnosed maybe because you have nutritional deficiencies or your doctor has flagged you as having some kind of nutritional deficiency, how you can work to correct those nutritional deficiencies and how you might work with someone to help them with that?
So a lot of the nutritional deficiencies, so that they just, if they're not gaining weight, if they're not growing well, anemia, so the low red blood cells. I'm trying to use the layman's terms here. So iron deficiency, if they're low, like in some of their B vitamins, different things like that, we try to correct it where we can. So usually when they start the gluten-free diet, the anemia goes away or improves. If they need vitamin supplementation to help throughout that point, we do encourage that. But once they start with the gluten-free diet and they're really strict and in following that, usually all those symptoms improve. They start to put weight back on. They're following more on the growth path. I didn't know if I say I work in pediatrics also, so mostly it's kids that I am working with and their families. I probably should have said that 20 minutes ago. That's okay.
If you weren't told you have nutritional deficiencies, you're probably all right. You don't need to go out and take a vitamin B12 every day or something like that. Is that right? Or is this something that everyone with celiac disease should be worried about at diagnosis?
So we typically do like screening tests for like what vitamin deficiencies you have. If you're not deficient, then you don't really need anything further. But then if you are, we give you supplementation. And when you're replete, meaning when your levels come back to normal, then we're okay. It's just because it's mostly due to the damage from the villi, the structures that absorb nutrients in your small intestine. So once that's healed with a gluten-free diet, you're less likely to have those.
I think it's important to remember about zinc as well. I think we focus a lot on iron and celiac disease. And then at the time of diagnosis, yes, you can have some deficiencies, but these have to be monitored over time because once you go on a gluten-free diet, depending on how healthy your gluten-free diet is or unhealthy, you might end up with a lot of these deficiencies as well. So important to monitor the iron, zinc, vitamin B12, folate. Just because those foods may not be totally fortified with those vitamins. Do you get your patients to take a multivitamin, Alan?
So I encourage it, at least in the beginning, because I do think there's a period of time, there's probably some deficiencies that have built up. What do I do myself? All right, I have multivitamins, which I took in the beginning. I take them from time to time because I think I should. The things that I take all the time, or as much as I can remember, are vitamin D, because first of all, I live in Massachusetts, okay? This is like a typical day, so, we don't see the sun all that much. And so there's chronic vitamin D deficiency in the population in general. It's only aggravated potentially in patients with celiac disease. And then I myself have iron deficiency, and so I'm taking iron supplements. And in fact, my diagnosis was based on developing iron deficiency anemia, and then I wound up having the endoscopy to look for the cause, and that's how the celiac disease was diagnosed. Even though I did have GI symptoms, I'm a bad patient, okay? I didn't go, I remember going to the doctor once and, you have a physical and they say, well, how often do you have bowel movements? And I would say, I don't know, 6, 7 times a day. And he said, well, that's not normal. I said, well, it's normal for me, because it was, okay? But until I developed the deficiency, I didn't actually get diagnosed.
So if someone has celiac disease and wants to know more about the gluten-free diet and wants to work with a dietitian, how can they find someone who is knowledgeable about celiac disease and the gluten-free diet?
So a couple things is your doctors might have referrals for dietitians. This is slightly personal. I guess, personal faux pas, I don't know. Some nutritionists or health coaches are not necessarily as knowledgeable as registered dietitians. Registered dietitians go through a lot of schooling. So it's scientific based that we're learning, a lot of hospital, inpatient care, outpatient care. It's a very intense program. So that's one thing. So try to really find a registered dietitian to educate you. Usually there's one that works in the gastroenterologist's office or they have a referral. Hopefully nobody in this room, but if you know somebody with type 1 diabetes that's diagnosed with celiac, a lot of the type 1 diabetes centers have registered dietitians on their team. A different specialists have dietitians on their team. So there's somewhere that you're gonna make that connection. But that being said, with people on Instagram now and influencers, a lot of them do have their credentials of being a dietitian, or they have been educated themselves because they live with celiac disease. Those, and the same in the diabetes community, a lot of people on Instagram that have type 1 diabetes. I tell my patients, kind of look at their credentials. Are they a registered dietitian? Are they a diabetes educator? Are they a gastroenterologist? Something that kind of makes them a little bit more credible, because there is so much personal information out there. So it's just really, you really want to look. Also, you want to see what they're saying. There's a lot of people in this room that I do follow on Instagram, and I do highly recommend to our patients, because they do a really good job of educating how to look for gluten-free menus and look for gluten-free restaurants. So it's just kind of really, you have to educate your patients or your family members, or what to look for when looking out into the community, because it can get a little weird. Also, from being a dietitian, when a patient comes to me with something that they found on the internet, sometimes I call it debunking, because then you kind of have to correct what somebody has 50 million followers, and then we're just well, that might not be so accurate. But I do the same for myself. If I see something on Instagram and it's related to something, I do ask that professional that is focused in that field. So that's something really important to keep an open mind about.
Do you have specific sources that you point your patients to? And I'd love for all of you to kind of weigh in on it.
I just want to start by saying, I just have to disagree with you, okay? You can't always trust your doctor, okay? Right? Okay?
That's fair.
You have to know when what you're being told doesn't make sense to you. There's nothing wrong with going and getting a second opinion, asking to see a specialist or a different specialist, if that's the case. I'm seeing motion there. Yes? Oh, okay. Yeah, thank you. All right, so I just want to lay that out there. Yes, for the most part, in an ideal world, you can trust your doctor. If I went to either of them, I trust them, okay? But, there are people who, just as patients have misinformation, some clinicians have misinformation too. And so you always have to be an advocate for you or your children, if that's the situation, and never forget that.
So where do you point your patients?
So for the most part, well, let's put it this way. Doctors have access to a variety of databases. There's one that I'm an editor for. There's another one that many clinicians have, and these have patient education handouts on all sorts of diseases. And so, if your doctor is handing you a handout, either, they've printed off of their electronic health record, or you can go to national societies, whether it be American Academy of Family Practice, the American Gastroenterology Association, things like that. They will, on their websites, they will have information about celiac disease, and that's going to be pretty reliable. Obviously, Beyond Celiac, I direct people to Beyond Celiac all the time, okay? But, if you're asking beyond that as a resource, those are the kinds of places I would go to, national societies.
You have big centers as well that you can go on their websites. They'll have some information. They might even have some names of dietitians and so on. But I agree with you. I think that, not that they're bad physicians, but just there's too much to learn. So it might not be their practice and something that they don't do on a regular basis. So perhaps, looking at the websites for big centers, looking at, groups like Beyond Celiac, probably the first place to start. But I would also say if there's something you're looking on social media on some platform, take that information with you to your doctor's visit and ask them rather than just sitting there and saying, well, should I or should I not? The good doctor will listen to you and will be able to have a dialogue or a conversation with you. It should not be adversarial. It's not going to be like I'm challenging you. It's more a conversation, and then you sort out the myths and things like that. So I think it's always helpful to come in with that information as well.
Yeah, and I do something similar. I print out handouts from my own institution, and I always tell patients to message me with any questions they get from social media, because there's a lot of misinformation out there. But I do understand that not all doctors are trustworthy, so.
Is it safe for celiac disease patients to eat wheat in Europe?
Gluten is gluten no matter where you live.
Okay, we hear that a lot. It seems like a lot of people think that there's a magic wheat in Europe, which is, would be wonderful, right? You get to take an international vacation and eat anything, but.
So a variation on this question that I've heard many times is like, well, is it because in the United States we've got these genetically modified wheat, and that's why there's so much more celiac disease? There isn't any genetically modified wheat. Corn gets genetically modified, but wheat doesn't. And so that's a myth that's out there. And so that, because like in Europe, I think they're down on the genetically modified corn. So there may be a difference in the corn you're getting in the two places, if you believe there's a difference there. But for wheat, there really isn't. I thought in Italy they were trying to develop a sort of gluten-free strain of wheat, but it's not commercial as far as I know. And it's like so many other things that we hear about in the celiac world. A lot of promise, a lot of hype, and then 5, 10 years goes by and like, where is it? Right?
So can you tell us, what do you think of as a role for AI in celiac disease diagnosis or management?
As we have talked about a lot, there's kind of a gap in diagnosis and management of patients. I think like clinical decision support tools could be a potential application, or even like when you get your small bowel biopsies to diagnose disease, and like the pathologist has to read it, very supporting the pathologist on there. But I do want to caution that AI is only as good as the data we feed it, and we feed it a lot of data from what we're doing, which isn't so great. So we really worry about garbage in, garbage out, biased outputs and things like that. So I think it could help. We just have to be really careful about how we apply it to celiac disease, in summary. So,
I'm sure many people have read some of the problems with AI, and this is something that I'm doing some work with as well. And there's this, what AI is doing is, it'll create an answer to a question based on fancy algorithms that are predicting what's the most likely next word that would be correct. And sometimes the things that get put in are, we would call them hallucinations, okay? Because it's not based on anything real. And so you have to be very careful. So I think all the medical groups are very cautious about things that are patient-facing, that are based on AI, that haven't been vetted by some type of clinical expert.
Last question, where do you all see, and Alan, you kind of said we've been promised a lot in the next 5 to 10 years that hasn't materialized, so hopefully this will materialize. But can you each just talk to me a little bit about where you think or hope celiac disease will be in the next few years, based on whatever you want it to be based on?
Yes.
There's still a lot of underdiagnosis. I would like that to be way better than it is right now. And even when patients do get diagnosed, like how they're managed and monitored, I think I would love that to be better. There's I know there's an area of hot research about finding some kind of cure for celiac disease. I don't know if we'll be there in 5 to 10 years, but I choose to remain optimistic. So, but yeah.
Thank you.
So I guess future for celiac disease for me would be really looking at, go back to my education theme in terms of how do you cope with this disease, the diagnosis. You've mentioned, Alan, a lot about the neurological. I think that we as practitioners have not done right by the patients who had neurological symptoms with celiac disease. I think we've always sort of poo-pooed that that's not anything. And there's definitely more research happening right now, and I'm not going to plug anything with the University of Chicago, but there is research happening looking at the neuropsychological effects from a celiac standpoint in pediatrics and in adults. So I think learning and educating that there's more to celiac than just abdominal pain. The second is learning a little bit more about testing. You know, we kind of are all sitting with the TTG as the basis, the be-all, end-all as a diagnosis or follow-up for celiac disease. It truly is not the best test. So there are a lot of groups that are working on looking at other tests that can be done and looking at it from an immunological standpoint rather than a blood test that looks at your small bowel. So thinking about celiac disease not as a GI disease, not as a just looking at the gut. This is an immunological gastrointestinal disease. It's not something that's only for the gut. So really learning more about that as a practitioner on what testing can we do that is more precise than an endoscopy, than a blood test that's a TTG. So that's from a diagnostic standpoint. And then I do believe that there'll be something coming out, but it's not going to be for all. So we need to learn more personalized. It might work for Alan, that there would be a medication, but it might work for my children because there's a different genetic makeup, there's a different immunological response that people have. So learning that it's not going to be a cookie cutter. Even now, a gluten-free diet doesn't work for everyone, but it's going to be even more with clinical trials that every person with celiac disease cannot be managed one way. Right now, we manage everyone the same way, that we just cannot. So that is going to be the future. When, I don't know, but it will be the future and soon, hopefully.
So first of all, I'm highly optimistic about the medium-term future, not necessarily the next 1 to 2 years, but certainly in the next 5 years or so. Over the last 10 years, the research has gone from a good understanding of the basic biology of what's happening with celiac disease to now, once you understand that, then you have the ability to start developing more targeted treatments that hopefully will make a difference. I think the two biggest areas are the things that really have been said already. One is to be able to diagnose in a different way. I'm not sure it's going to replace endoscopy in all patients, but you know, the classic example is the patient who's already on the gluten-free diet and doesn't know, do they have celiac disease or not? Can they start reintroducing gluten in their diet safely or not? I think there's got to be better ways of making that diagnosis than a gluten challenge that risks people feeling very ill and very poorly. And I do think we are going to see in the next 5 years, maybe 7, but that time frame, I think we're going to see drugs being put forward to the FDA for treatment of celiac disease. Now, when that happens, they're going to target the people who the gluten-free diet doesn't work for, okay? That's how it always is. You focus on the sort of what the FDA perceives to be the greatest need. I remember I was in a meeting with Alice, with a pharmaceutical leader, who was saying, if we develop a drug for treating people who have refractory celiac disease, then anybody with celiac disease is going to want to take it, and so that they don't have to follow the gluten-free diet. And he was saying this as if this was a bad thing. Okay, I'm like, no, that's the whole point. Okay, this is what we want. And I think we will see some kind of treatment that allows people, even if it just decrease, you can eat more freely without having to be quite as vigilant, so that a minor cross-contamination doesn't result in some type of significant adverse event. Even if I can't have, I'll quote unquote, real pizza, again, if I don't have to worry about, okay, something was made in the same fryer, therefore that's off. Right now I try and be as strict as possible, and I'd like to loosen up a little bit. Something is going to be coming down the pike. I believe that's what our organization is supporting. We fund research for these types of activities, and I really believe something will be on the horizon before very long.
I think none of these things can happen unless we all get together as a community. I mean, looking at medications or even the challenge, the gluten challenge, currently we say you need to be challenged for 6, 8, 12 weeks. And some people get very sick. So there are studies being looked at that the challenge can be smaller, but then you're testing some other immunological marker rather than the TTG, which takes long to kind of come up in the blood test. So making it a little easier, but everyone in the group has to come together. Clinical trials, you have to agree to be in the clinical trials to get any of these medications on board.
So my position's coming from working closely with kids with type 1 diabetes, and there's not a cure yet. So we have a lot that we have to deal with, discussing with families. It comes around that. So my life kind of revolved around there's a cure coming. So what I say is the care, the education, the awareness are really important, as what was said. But also don't overserve it under promise. So that being said, when I was 8 years old, my mom came to me and said, hey, if you could take one pill that cured cystic fibrosis, would you do it? Well, yeah, of course. 20 years later, it was 3 pills, and it didn't cure CF, but it ultimately changed my life. Diabetes. I stopped taking injections. I'm on an insulin pump 25 years after I was diagnosed with diabetes, that I really don't have to think about my diabetes. I still have to count my carbohydrates and do things, but it puts the pressure a lot less on me. So I just don't, especially when it comes to pediatrics, don't say there's a cure coming in 2-5 years, because it has been, as I said, it's been over 25 years where, I was diagnosed with diabetes and there's a cure. Or a kid, I used to babysit with 14, he was diagnosed at 4, parents said 5 years. That's income. So it's very, it's kind of like an off-putting thing because they're looking so forward to something. So I think that's really important, but just the awareness, the education, and also, trials are really important. So if your provider asks if you want to participate in a trial, that's something also really cool to look into, because it's something that can ultimately change your life and change how you look at food and change of how careful you have to be. So that's just my closing comments in that position.
I have to agree with everything you've said and go back to our great opening speaker, because if you want to take control of this, if you want to make a difference in a way that leads to a faster attainment of what we want, actual treatments, maybe even a cure one day, enrolling in clinical trials is the single most important thing we can do. And I'm on a list through Beyond Celiac where I routinely get emails saying there are clinical trials, click here to see if you're eligible. If you haven't done that, sign up for that. Often I'm not eligible for one reason or another. Just because you're on the list doesn't mean you're going to suddenly participate in 10 different trials. But I look forward to being able to participate in one, because I know without people stepping up and saying, I'm willing to be part of this trial, we're not going to make any progress.
Great. That's a great point and a great segue into our breakout sessions. So thank you all for your time. We really appreciate you being here.